features of the heart in this setting is anomalous veno-atrial connections. So that is what we're going to be discussing today. And I'd like also to extend it once more because I want to suggest to you that there are 4 basic patterns of arrangement. And they are the usual arrangement, and then the ones that are not usual, by definition, are heterotaxic. But it's the ones with the 2 isomeric subsets on which we're going to be concentrating today. But before we do that, Grace has a few words for you about the forthcoming program. So Grace, tell them what they can expect in the coming months.
So hi, everybody. Welcome to Congenital Heart Academy. We are, as usual, very happy to have all of you here. And please follow us on social media. And these meeting that we're having today, the previous meetings and the next series are going to have on our Congenital Heart Academy YouTube channel. So please subscribe to the channel, then you can watch all of that. We are very happy to announce that Dr. Anderson is going to stay with us for 2 more months. So we have November and December, every Friday before Christmas, we have a new appointments. So for November, we are going to start with the AV valves. We are going to talk first about Ebstein malformation and then mitral valve malformations. After that, we are going to talk about the arteries. So we are going to talk about the development and the anatomy of the arterial roots. Then we are going to talk about aortic stenosis, valvar, subvalvar, and supravalvar. Then we are going to talk about aortic rings. And then we are going to talk about the fifth arch, and then coarctation and interruption of the aortic arch. So we have a lot of things for you for the next couple of months. We hope all of you can join us and enjoy. Just to remind you that we are going to have on the 10th of November, another series of Dr. Gil Vernovsky, another meeting. We are going to talk about something that is very interesting. It's about how we behave on the cardiac ICU. So about resilience, about fragility and anti-fragility. This is really worth watching. So we hope that all of you can join us on the 10th of November. So now we are going to start with Dr. Anderson. Thank you again, Dr. Anderson, for doing this for us. We really appreciate it. It's been very important for our knowledge and for sure to take a better care of our patients.
Well, good afternoon to you, ladies and gentlemen. So this afternoon, we're going to be discussing abnormal veno-atrial connections. But I'm going to start by emphasizing if we are to understand the abnormalities, it's axiomatic, of course, that we need to understand the normal arrangement, but this is the more so with regard to abnormal veno-atrial connections, because not only must we appreciate the normal arrangement of the veins and the way they join to the atrial chambers, but we must also appreciate how the atrial chambers themselves are arranged. And as we discussed last week, the arrangement of the atrial chambers and the veno-atrial connections is intimately related to so-called heterotaxy or isomerism. So in a way, the lesions that we're going to be discussing today are very much a follow-up to what we were discussing last week, the interrelationship between so-called heterotaxy, or as you know, what I prefer to think of as isomerism. Because it also follows that a usual arrangement of the veno-atrial connections can only be found when the atrial appendages are in their normal position, or when the entirety of the arrangement is mirror imaged, and then that would be mirror imaged for the normal arrangement, and the veno-atrial connections would similarly be totally mirror imaged, but as I will be discussing very shortly, that is still an abnormality when compared to the normal arrangement, so itself could be argued to be heterotaxy. But what we discussed last week is that when the atrial appendages themselves are isomeric, and that is when the two appendages are mirror images of each other in the same individual, then any way that the systemic veins and the pulmonary veins are connected to those atrial chambers with their own mirror-imaged atrial appendages will have to be abnormal, because there is no way that the pulmonary veins and the systemic veins can normally be connected to a heart which has either two morphologically right atrial appendages or two morphologically left atrial appendages. Now, there is a caveat when I say that, because although the veins, as I will show you, can be abnormally connected to those atrial chambers, the drainage they produce can be as expected for the normal individual, or that venous drainage can be mirror imaged. So that is one potential caveat. It follows nonetheless that the first step in your diagnosis as clinicians must be to establish the presence in the same heart of morphologically right and morphologically left atrial appendages. And that, as we discussed last week, and as Dr. Cohen emphasized in her presentation, is not always easy for you. But what is much easier for you is to look at the entire individual, and then it is much more readily possible to distinguish whether the individual itself has normally arranged organs or whether the entirety of those organs are mirror imaged. Now, this is important because, as we discussed last week, as we're going to discuss again today, for me as a morphologist, I can look at the extent of the muscles, the pectinate muscles, relative to the atrioventricular junctions. And that permits me to distinguish what is morphologically right, what is morphologically left. As the resolution of your clinical techniques gets better and better, I believe you will be able to do that. But it remains the case that at the moment, that is not always possible. But as I discussed with you last week, and as Dr. Cohen also emphasized in her presentation to you, when you as clinicians look at the combination of lesions that make up what is called heterotaxy, what I like to call isomerism, almost always on the basis of those combinations, it is sufficient for you to determine whether that individual has either right or left isomerism. But when you are doing that, I would emphasize one other important fact, because it's also necessary that you distinguish those isomeric variants from total mirror imagery. Now, this is a subtlety that was not entirely obvious in Dr. Cohen's presentation, which I looked at shortly before making this presentation for you on veno-atrial connections, because Dr. Cohen didn't quite get correct my understanding of mirror imagery. Because what I tried to explain to you last week is that you can have total mirror imagery when the entirety of the arrangement of the individual is itself the mirror image of what you usually expect. And that is what most of you call situs inversus. And that is different from the isomeric variants, but as Dr. Cohen emphasized, and as I agree, the essence of isomerism is when we have mirror imagery of the two sides in the same individual. But what I also pointed out to you last week, in that total mirror imagery is itself not normal. Arguably, that is heterotaxic. So for me, I would have three variants of heterotaxy: total mirror imagery, right isomerism, and left isomerism. And it is in that context that we need to be considering normal veno-atrial connections. And as I say, for you as clinicians, you are able now to take note of the entirety of the individual. And bronchopulmonary morphology is particularly important in this setting, because if the veno-atrial connections are anomalous and you find additional abnormalities within the heart, it would be most unusual to find an isomeric pulmonary arrangement in combination with usual arrangement of the atrial appendages. In other words, what many of you still call situs solitus. So let me illustrate to you one case before we move on to consider anomalous veno-atrial connections. This is one of the splendid cases that has been illustrated and photographed by Diane Spicer. So here, as you can see, she is showing you the bronchial tree. And what you see is that both of the bronchuses are the same size. They are both crossed by the pulmonary arteries before they give off their first branch. This, in other words, is left bronchial and left pulmonary isomerism. But if we know there is left bronchopulmonary isomerism, that is giving us a key to what is going on in the heart, but we don't know for sure what is within the heart. So here is the heart from this particular case. I'm showing you here the picture we've taken of the right-sided atrium, and unequivocally, this right-sided appendage is long, it is tubular, and as you will see very shortly, the pectinate muscles are confined within the tubular appendage. It is a right-sided, morphologically left appendage. But look now at the veno-atrial connections. There is a right superior caval vein bringing systemic blood back to this right-sided atrium. There is, however, interruption of the abdominal inferior caval vein, and the venous return from the abdomen is returning to the right superior caval vein through the azygous system of veins. There is also, however, an inferior channel that is bringing back systemic blood from the liver to this right-sided atrium. There you see the pulmonary veins, and they are connected to the left-sided atrium. Now, when Diane opens up this right-sided atrial chamber, there is an extensive array of pectinate muscles related to the superior caval vein, but the left superior caval vein is also draining to this right-sided atrium. So all the systemic venous return is coming to this right-sided atrium, but it has a smooth vestibule and it has a morphologically left atrial appendage. And it is the morphologically left atrial appendage that is determining the atrial arrangement. Because here we see that this atrial chamber receiving the systemic venous return is connected to a right-sided morphologically left ventricle. So this is a potentially complex arrangement. Because when we turn around the heart and we look at it the other side, we see that the other atrial appendage is also morphologically left. So matching the left bronchopulmonary isomerism, we also have isomerism of the morphologically left atrial appendages, but the pulmonary venous return is to this left-sided atrium with a morphologically left appendage, and this left-sided atrium with a morphologically left appendage is connecting to the left-sided morphologically right ventricle. So how do we describe this? The patient has usual venous drainage because all the systemic veins are coming to the right-sided atrial chamber. All the pulmonary veins are coming to the left-sided atrial chamber, but both of the atrial chambers have left atrial appendages. So the atrioventricular connections are mixed in the setting of left-handed ventricular topology. And we should not be diagnosing this as discordant atrioventricular connections because of the presence of the isomeric atrial appendages. This is a very subtle point, but it is an important point because the sinus nodes go with the atrial appendages. So in this particular patient, there will be an abnormal arrangement of the sinus nodes. So these are the nuances that we can now make when we consider isomerism versus veno-atrial connections. So on that basis, let me outline for you what are the normal veno-atrial connections and how those connections can be abnormal. So in the normal situation, all the systemic veins come back to the systemic venous sinus. And they are superior caval vein, the inferior caval vein, and the coronary sinus. We can make a list then of the potential abnormal veno-atrial connections on the systemic side. So we can anticipate anomalies of the superior caval vein. We can anticipate that the inferior caval vein can connect in anomalous fashion, and we can expect abnormalities of the coronary sinus. Indeed, on very rare occasions, all of those veins can connect anomalously. But as I'm going to explain to you, I have never seen such a case in an autopsied specimen. And there is one other strange vein that we need to think about when we are contemplating abnormal systemic veins, and that is the levoatrial cardinal vein. So now I'm going to take you through the list of the way in which these various entities can drain anomalously. So let's start with anomalies of the superior caval vein. And here, the commonest, perhaps the most important, is persistence of the left superior caval vein. Now, during development, the venous channels are symmetrical. And it is during development that the normal left-sided channels regress to a certain extent, with the left superior caval vein ending up as the coronary sinus. But on occasion, the left venous channels can persist and they can drain through the persisting left superior caval vein. However, we can also have abnormalities of the right superior caval vein, and that can drain to the left atrium, or the right superior caval vein can be absent. And whenever we have absence of the right superior caval vein, all of the venous return will come back to the right atrium through the persistent left vein. So again, persistence of the left superior caval vein is perhaps the most important and certainly the most frequent, usual atrial arrangement of the systemic venous anomalies. And here you see a nice example of persistence of the left superior caval vein. We're looking at the heart from behind, and there is the venous channel is coming back and is opening into the right atrium through the enlarged coronary sinus. The course of the persistent left superior caval vein is constant, and always it enters the left atrioventricular groove between the attachment of the pulmonary veins to the left atrium and the left atrial appendage. And this reflects the course initially during development of the left superior cardinal vein. If we turn the heart and we look at it from the right side, then we see the pulmonary veins are connecting to the normal left atrium. We see that in this particular instance, there is a deficiency of the ova fossa, but now in presence of a persistent left superior caval vein, the scene is dominated by the enlarged mouth of the coronary sinus through which the persistent vein enters the right atrium. An important point in this setting is the presence of a connecting vein between the left superior caval vein, the right superior caval vein, brachiocephalic vein, and that vein may or may not be present, but presence or absence of that vein is a very important clinical feature. Here you see a nice heart with absence of the right superior caval vein. So in this instance, all of the blood from the top part of the body will be returning to the right atrium through a persistent left superior caval vein, which will drain through an enlarged mouth of the coronary sinus. But in this particular heart, the right caval vein is atretic, but there is a morphologically right atrium, there is a terminal groove, and so we are going to find the sinus node exactly where we expect it to be, within that terminal groove, immediately beneath the epicardial surface. So the absence or the atresia of the right superior caval vein does not change the arrangement and the relationship between the persisting systemic venous sinus and the morphologically right atrial appendage. Now, this is a very important and interesting finding, because here you are seeing overriding of the superior interatrial fold by the superior caval vein. And the orifice of the superior caval vein is looking almost exclusively into the morphologically left atrium. And this is the explanation for me that accounts best for attachment, superior caval vein to the left atrium. If you look at the cases that have been described, typically they are said to be biatrial connection of the superior caval vein. And what you should note here is the attachment of the right pulmonary veins, because the right pulmonary veins are connected into the posterior wall of this overriding superior caval vein whilst retaining their left atrial connection. And as we have now discussed on several occasions, this is the phenotypic feature of the sinus venosus defect. And indeed, it is my belief that when the caval veins attach to the morphologically left atrium, they do so in the presence of a sinus venosus defect, even if on occasion the wall of the overriding caval vein can be attached to the superior interatrial fold, so it seems as if there is spontaneous closure of the pre-existing sinus venosus defect. And I find that the only rational explanation as to how the caval veins can get into the morphologically left atrium. I'm going to emphasize that again in the setting of the inferior caval vein, and I'll discuss it with you in the setting of totally anomalous systemic venous connection. So as I say, we are making lists, we are considering the way in which the different veins can show abnormalities. So let's move on and let's look at anomalies of the inferior caval vein. Now, just as I've shown you the superior caval vein connecting to the morphologically left atrium, on rare occasions, the inferior caval vein can connect to the left rather than to the right atrium. But this is exceedingly rare. And indeed, I have never seen an autopsied example in which I was convinced that the inferior caval vein was totally connected to the morphologically left atrium. But they are described. And here again, it's my belief that when they are described, they are seen most usually in the setting of a sinus venosus defect. They can also be found, however, in the setting of a persistent eustachian valve. And I'll discuss that with you in a moment. But what is much more frequent is interruption of the inferior caval vein with continuation through the azygous system of veins. I've shown you an example of that already in the setting of left isomerism. So whenever we find interruption of the inferior caval vein, we should be suspecting left isomerism, but on rare occasions, it can be found with usual arrangement. So let me show you these features in a little more detail. Now, this to me was what I thought was the commonest way in which the inferior caval vein could be connected into the left atrium. And that is in the setting of a persisting eustachian valve. And I know of numerous occasions in which this has been described at surgery, when the surgeon has gone in to close a defect within the oval fossa and has mistaken the eustachian valve for the rim of the oval fossa and has placed a patch so as to put the inferior cable vein into the left atrium. I was unaware that no cases had been described of spontaneous connection of the inferior cable vein to the left atrium, but I now know that Lucille Hoyel and her colleagues at Necker, in Hôpital Necker in Paris, have now described a case in a fetus in which they have found the eustachian valve attached to the rims of the oval fossa, connecting the inferior cable vein into the left atrium. And this is an entirely rational means of explaining this malformation. I was surprised when Lucille also discovered that it had not previously been described before. So in fact, if that is the obvious way in which the inferior cable vein can get into the left atrium, this is the alternative way where the inferior cable vein comes up through the diaphragm and seems to drain directly into the base of the morphologically left atrium. And again, to me, this can only be logically explained on the basis of coexistence with an inferior sinus venosus defect. And I have seen no such examples, but they are described within the literature. So this is the other rare variation, because what you are looking at here is the azygos vein. And in this heart, the azygos vein is bringing back all the venous return from below the diaphragm. There is the superior cable vein receiving the azygos vein. The venous return from the liver, however, is connecting directly into the base of the right atrium. But unequivocally, in this instance, it is in association with a morphologically right appendage. And the heart itself, in this instance, was anatomically normal. There was, however, left pulmonary isomerism. And in this combination, there was also biliary atresia. And this is one of those instances in which the abdominal organs can be heterotaxic. There can be pulmonary isomerism and bronchial isomerism, but the heart itself inside is anatomically normal, albeit with interruption of the inferior cable vein and azygos return of the drainage to the superior cable vein. And this combination does exist, but I would stress again, the heart itself is anatomically normal with usual atrial arrangement. So let's move on, and let's now think about the anomalies that can affect the coronary sinus. Now, I've already discussed with you the most important, which is persistence of that left-sided venous channel found during development, the left sinus horn draining the left cardinal vein, and that persists again as the coronary sinus. But the other anomalies are fenestration of the walls between that coronary sinus and the left atrium, and in its extreme form, that fenestration can be complete, and that is what we call unroofing of the coronary sinus. And on occasion, the mouth of the coronary sinus can itself be atretic. So here is an example with fenestration of the walls of the coronary sinus. You're looking at the heart from behind, so we've opened out the coronary sinus. There is the cavity of the left atrium, and there are two fenestrations which join together the cavity of the coronary sinus to the cavity of the left atrium. And here is the extreme form of fenestration. Because here I'm showing you the heart from behind. We've opened up the left atrium, and there you see the left superior cable vein, which is joining the roof of the left atrium, and it is doing so in the position we expect it, sandwiched between the appendage and the connections of the pulmonary veins to the roof, the remainder of the roof of the morphologically left atrium. And there you see now the mouth of the coronary sinus, and the mouth of the coronary sinus is now functioning as an interatrial communication. So this is the coronary sinus interatrial communication. It is not an atrial septal defect, because if you look carefully there on the left side of the atrial septum, you can see the horns of the oval fossa, and the oval fossa in this particular heart was intact. So the mouth of the coronary sinus is functioning as an interatrial communication, and that is because the entirety of the two walls that should be separating the cavity, the coronary sinus, and the cavity of the left atrium have disappeared. We don't know why this should happen. We can see that there is a spectrum from fenestration to complete unroofing, but without question, when it occurs, the left caval vein is draining to the atrial roof, and the mouth of the coronary sinus is functioning as an interatrial communication. This is the other side of the coin, because here in the morphologically right atrium, where we would expect to find coronary sinus, it is atretic, and this is produced by a persistent and complete Thebesian valve. And then the blood that should be returning to the heart from the coronary venous system is now tracking retrogradely through a persistent left superior caval vein and is draining into the heart through the right caval vein. So an important finding, because this is an anomalous course for the coronary venous drainage. So that's another of the lesions, the levoatrial cardinal vein. This is a very strange channel, because in reality, it's neither levo, atrial, nor cardinal. I think it is better explained on the basis of a pulmonary to systemic venous collateral channel. And we find this unusual channel providing overflow in the setting of mitral atresia and an intact oval fossa. So here you see a diagram showing you mitral atresia, also found with absent connection, with the anomalous channel is joining the pulmonary veins into the superior caval vein. Now, this is an instance in which the pulmonary veins themselves are connecting in normal fashion, but the pulmonary venous drainage is anomalous. And I'll come back to that when we discuss pulmonary venous drainage, and because pulmonary venous drainage, anomalous pulmonary venous drainage, is not necessarily the same thing as anomalous pulmonary venous connection. So let's look at an example of the levoatrial cardinal vein. And here we see it. The pulmonary veins are coming back to the left atrium. The pulmonary venous connections are appropriate, but the left atrium has no direct outlet because the oval fossa is intact. There is mitral atresia. So the overflow from the pulmonary veins goes through this anomalous vein, which takes a serpentine channel, curling round the superior caval vein and connecting into the superior caval vein so that the blood reaches the morphologically right atrial appendage. We call this levoatrial cardinal vein, but as I say, it is a collateral channel between the pulmonary veins and the systemic veins. Now, I need to finish by saying a few words on totally anomalous systemic venous drainage to finish the systemic side. And we find this when not only the superior caval vein, but also the inferior caval vein and the coronary sinus drain to the left atrium. And we need to distinguish this from left isomerism, because I've already shown you an example where in Diane Spicer's heart, the superior caval vein receiving the azygos return, the hepatic veins, the left superior caval vein, were all connecting to a right-sided atrial chamber that had a morphologically left appendage. So you could argue that that is totally anomalous systemic venous drainage, but this was in the setting of left isomerism, not in the setting of usual atrial arrangement. So I have never seen an example of totally anomalous systemic venous connection or drainage in the setting of usual atrial arrangement. And as far as I'm aware, no cases have been described at autopsy. But my good friend and colleague, Saurabh Gupta at the All India Institute in New Delhi has seen such cases, and such cases are found in the clinical setting. It's easy to account for the superior and the inferior cable veins connecting to the left atrium by means of a sinus venosus defect. Harder to explain why the coronary sinus should also drain into the left atrium. Presumably, it is unroofed. All I can say is that these cases have been found in the clinical setting. You need to be aware of the potential for totally anomalous systemic venous drainage, but you must distinguish it from left isomerism. So let's turn our attention now to the pulmonary venous connections. And as you are all aware, the typical normal finding for the morphologically left atrium is that 4 pulmonary veins drain at each corner of the dome of the atrial chamber. There is now known to be quite marked variation in that. Oftentimes you can have a roof vein. 2 of the veins on one side may share an orifice, but to all intents and purposes, we can think of the normal arrangement as the 4 veins coming to the roof of the dome of the left atrium. Now, I've already introduced you to the fact that when we are considering abnormalities of the pulmonary veins, we must distinguish between anomalous connections and anomalous drainage. I've shown you an example where the veins can be normally connected but still drain anomalously. And that, of course, is in the setting of the levoatrial cardinal vein. We can also see that to a lesser degree when there is fenestration of the coronary sinus. So what we need to do is we need to describe the connections. And now you can distinguish that as clinicians. You can see whether the pulmonary veins are normally connected or abnormally connected. And again, the key here is that the normal connections are sandwiched between the course of the persistent left superior cable vein and the systemic venous sinus connected to the morphologically right atrium. So when we find anomalous connections, we need to describe their extent. The extreme form is totally anomalous connection. We find that when all of the drainage from both of the lungs drains anomalously. But we can have unilateral anomalous connection, and that's when the drainage from only one of the lungs drains anomalously. We can have partially anomalous connection when just one of the veins, or 1 or 2 of the veins from one of the lungs is draining anomalously. And of course, these connections can be mixed with any combination above. So knowing that there is anomalous connections, we then need to know where are the connections connecting to. And we divide this into supradiaphragmatic and infradiaphragmatic. So the supradiaphragmatic is most usually to the superior cable vein, but it can also come, as I will show you, through the azygos vein. And that is an interesting but rare variant of supradiaphragmatic connection. We can have connection via the coronary sinus to the right atrium, and that is one form of so-called cardiac drainage. If the pulmonary veins connect directly to the morphologically right atrium, however, in my experience, we should always be thinking of right isomerism, and I'll discuss that with you in a little more detail. But then we can also have drainage infradiaphragmatically and beneath the heart, and almost always, in my experience, that is to the portal venous system. I am aware of cases described to the inferior cable vein, but again, I've never seen such an example. Let's not forget, however, the partially anomalous connections, because there are very important associations with partially anomalous pulmonary venous connection. One of those is the scimitar syndrome, where not only do we have partially anomalous pulmonary venous connection, often infradiaphragmatic, we can also have sequestration of a pulmonary lobe, and we can have anomalous arterial supply. Particularly important when we consider partially anomalous connections, however, is the sinus-venosus communication. We've discussed that already. Most usually it is to the superior caval vein. It can be to the inferior caval vein, and indeed it can be intermediate between the two. And I suppose it can be combined in the setting of totally anomalous systemic venous connection. So there is this association which is important when the caval veins are connected to the left atrium, and to me that is the most logical explanation for connection of the systemic veins to the left atrium. The key, the oval fossa, or at least the rims of the oval fossa, must be intact. There can be a coexisting defect within the oval fossa, but its rims must be recognizable, because the sinus venosus defect is a veno-venous malformation. It is anomalous connection of one or more of the pulmonary veins, with that vein or veins retaining its left atrial connection. And we can make a very nice comparison between partially anomalous connection of one of the pulmonary veins, as you see here. You're looking at the right side of the heart in this instance, and there is the right upper pulmonary veins, and in this instance they are draining directly into the superior caval vein. Partially anomalous connection of the right upper lobes to the right superior caval vein. The right lower pulmonary veins, along with all the left pulmonary veins, are connecting into the morphologically left atrium. Now, this is a sinus venosus defect. And if you look at the situation as in the heart I just showed you with partially anomalous pulmonary venous connection, you see that the lower pulmonary veins in this instance are connecting to the left atrium. But look at the location of these upper veins from the right lung. They are in exactly the same position as the partially anomalous connection I showed you just a moment ago. So what we have here is partially anomalous connection of the right upper pulmonary veins to the superior caval vein, but with retention of the connection of the anomalous pulmonary veins to the left atrium. And it is that retention of the left atrial connection that gives us the sinus venosus defect. In most instances, as we have seen, the caval vein usually overrides the superior rim of the oval fossa. But in this instance, look at the extensive distance between the sinus venosus defect and the oval fossa. And it is this feature that tells us that the sinus venosus defect is a veno-venous malformation. It is not a problem of the atrial septum, and that is why the sinus venosus defect is an interatrial communication, but not an atrial septal defect. But let's move on and let's concentrate on the main subject, which is anomalous pulmonary venous connections, totally anomalous pulmonary venous connection. And this shows you what you see when you have tipped the heart from its pericardial cradle. The movement of the heart out of its pericardial cradle is called the Taussig maneuver, and that was emphasized by the mother of pediatric cardiology, Helen Taussig. So in this instance, we've flipped the heart rightwards out of the pericardial cavity. And there you see the confluence of the four pulmonary veins. And in this instance, the confluence is ascending through the left paravertebral gutter. It's opening into the brachiocephalic vein, and then it's crossing over and entering the heart through the superior caval vein. And this is the typical arrangement we see in supracardiac and supradiaphragmatic totally anomalous pulmonary venous connection, drainage into the superior caval vein. There is, however, a variant. And I've learned much more about this variant over the last week when I gave a presentation to the Indian Association of Cardiothoracic Surgeons on anomalous pulmonary venous connections, and Dr. Jagannath from Hyderabad explained to me that he had seen a series of cases with this variant. And he's done an extensive literature search, and this is called either the meandering pulmonary vein, and on occasion, the intrapulmonary anomalous pulmonary connection. But this is the only one I've seen of this type, and the vein for sure is meandering, but it is not intrapulmonary. And what you are seeing is that the left veins take a horizontal channel. They cross from the left side to the right side, and they pick up, as you see, the veins from the lower lobe of the right lung. The venous channel then ascends in the right paravertebral gutter, and it picks up the veins from the right upper lobes, and then it drains into the azygos vein. So it is a variant on supracardiac connection, variously described, as I say, as the meandering vein or as the intrapulmonary vein. They're not for sure all intrapulmonary. This is the only one I've seen, and it's associated with right isomerism. Dr. Jagannath has put together a series of these, and so it is a rare variant of supracardiac totally anomalous pulmonary venous connection. The other variant of supracardiac connection is the cardiac connection, and rarely this can be to the right-sided atrium. As I've shown you, that can happen in the setting of isomeric left appendages, and then that would be normal. It would not be anomalous pulmonary venous connection. More usually, we find this when we have isomeric right appendages, but then this is anatomically abnormal, and it's very rare to find direct connection of the pulmonary veins to the morphologically right atrium in the setting of usual atrial arrangement. But my good friend and colleague, Norman Silverman, tells me that he has seen several cases. More typically, however, we find cardiac connection via the left superior caval vein or drainage to the coronary sinus. So let's look at those variants. This is the arrangement in right isomerism. All the pulmonary veins are draining to the roof of the right-sided atrial chamber, but there is absence of the coronary sinus, and unequivocally, the pectinate muscles are extending all the way around the right atrioventricular junction. So here we have connection to the right-sided atrium in the setting of right isomerism. Oftentimes, in fact, we have cardiac connection in the setting of right isomerism, but this is the more usual variant. You see in this instance, unequivocally, we have isomeric right appendages. You can see how the pectinate muscles are mirror images of each other. In this instance, there is a common atrioventricular valve connecting to a dominant left ventricle. And again, absence of the coronary sinus. Is absence of the coronary sinus that is a uniform feature of right isomerism. But there you see the typical arrangement of the pulmonary veins when there is cardiac connection. In the setting of right isomerism, they're coming together into a confluence, a midline confluence. You see there's a little bit of myocardium surrounding the veno-atrial junction, and it's draining into the midline between the two chambers, both with morphologically right atrial appendages. But in the setting of usual arrangement, when anomalous pulmonary venous return is to the right atrium, then in my experience, this is the typical variant. The blood is coming back through the coronary sinus. There, I'm showing it to you from the left side. We see the cavity of the left atrium, and there are the pulmonary veins. There is a short channel between the pulmonary veins and the coronary sinus. And it's argued, is this a left superior cable vein? Well, to all intents and purposes, I think it is the same as persistence of the left superior cable vein. So I am happy to consider this as the persistent left superior cable vein. And for sure, it is bringing all the pulmonary venous return into the coronary sinus with its enlarged mouth and taking it over into the morphologically right atrium. So the other variant, of course, is infracardiac and infradiaphragmatic. And in my experience, that has always been to the portal venous system. And the key feature here, because it's going into the portal venous system, this is going to be obstructed within the liver after closure of the venous duct. I am told that these connections can also go to the inferior cable vein. I've never seen such a case. But this is the typical example of infradiaphragmatic and infracardiac totally anomalous pulmonary venous return. Again, the heart has been flipped out of its pericardial cradle by the Taussig maneuver. So you see the apex of the heart there pointing over to the right. And what you see very nicely, having removed the body of the left atrium from its pericardial cradle, there is no communication with the pulmonary veins. The pulmonary veins are coming together as the inverted Christmas tree, the confluence, and then instead of connecting to the body of the left atrium, the confluence is turning north, and there you see turning south, and there you see the descending vein passing down through the diaphragm and ending up in the portal venous system. So that brings us to the matter of obstructed pulmonary venous drainage. Because always when you have infradiaphragmatic and infracardiac drainage, there will be obstruction subsequent to closure of the venous duct. But we can also have obstruction with the other variants. Drainage to the coronary sinus can be obstructed in the setting of a persisting Thebesian valve. I suppose on occasion that could even be totally obstructed should the Thebesian valve be atretic. And we can also have it in the setting of supracardiac connection with the so-called bronchopulmonary vice. So here is the bronchopulmonary vice. Usually the venous channel is not between the pulmonary artery and the bronchus, but should it pass between these two structures, then it will be gripped by them in the so-called vice. And here you see a nice example of the bronchopulmonary vice. There are the right and left pulmonary arteries. There is the bronchus, and there is the narrowed channel as it passes through that vice here in the setting again of right isomerism. So in many ways, all I have done today is give you a list of what is possible. Because there is no question that if you know the normal arrangement, that provides the basis for understanding. What I've been showing to you today is that the anomalous connections can exist in isolation. They can be found as associated lesions, but we should always bear in mind the possibility of isomerism. And particularly when you have anomalous systemic veins and anomalous pulmonary veins, to me, that rings the bell that we're going to be dealing with isomerism of the atrial appendages. So we must put all of the information that I provided with you today into the setting of what we discussed last week, so-called heterotaxy, better considered, to my mind, in the setting of as isomerism. But remember, the two isomeric variants also need to be distinguished from total mirror imagery, and it is those three combinations, total mirror imagery, right isomerism, left isomerism, that are other than normal and hence heterotaxic.
Thank you very much, Dr. Anderson. As usual, it was an amazing talk. And thanks for joining us today, Dr. Silverman. We are very happy to have you with us. Do you have any initial comments about this lecture?
You're muted, Norman. Norman, you're still muted.
Thank you, Bob. Good morning or good afternoon. That was excellent. Thank you very much for a very all-encompassing look at Venus anomalies. I only have one comment that's clinically important, and that's when you see totally anomalous pulmonary venous return where there's mixed connections. For example, Diane Spicer has some beautiful examples of the left-sided veins draining vertically to a innominate vein, and right-sided veins draining below to a almost in a scimitar fashion to the inferior caval vein. And I think as a clinician, we have to worry about when we look at venous anomalies, particularly with echocardiography, is to check for other sites of drainage, because these little veins that drain in different fashions, like 3 veins to the coronary sinus and 1 vein to a vertical vein, create a lot of problems for the surgeons. And so I wanted to know whether you have seen many of those examples.
It's a good point that you make there. And in fact, it's as you said that, it occurred to me that indeed, when you have in the scimitar syndrome, I mentioned that in the scimitar syndrome, oftentimes the anomalous vein drains infradiaphragmatically. And as you say, in that setting, it does drain into the inferior caval vein, doesn't it? So it's unusual when you have partially anomalous pulmonary venous drainage that's going infradiaphragmatic for it to go into the portal venous system. I've never thought of that before. And so you bring up a very good point there. And as you say, in Diane's case, where the left lung is draining supradiaphragmatically, the right lung is draining infradiaphragmatically, again, that is going into the inferior caval vein. So let me put it back to you. Have you ever seen totally anomalous pulmonary venous connection to the inferior caval vein rather than to the portal system?
No, I have not seen that.
And isn't that interesting? I've not thought of that combination before, that when it's partially anomalous connection infradiaphragmatically, it does go into the inferior caval vein. And yet when it's totally anomalous, it goes into the portal venous system.
Mm-hmm.
And so I've never thought of that before. So that's a very interesting point. And I think you're right to emphasize the importance of the mixed connections. I mean, I touched upon mixed connections. My presentation today, as you will all be aware, went on for quite a long time. So I didn't want to overstay my welcome, but you're right. There are multiple combinations of mixed, and I said anything is possible. So obviously you can't go through the whole gamut of possibilities, but the point you raise is a very good one. And I mean, you've illustrated all of these, have you not, in the chapter on your app? Do you want to tell us about your app?
Well, I looked at anomalous pulmonary venous connections rather than systemic venous connections. But the app is available at md1world.com, www.md1world.com, and has many of the images that you have shown today correlated with echocardiographic images to help the pathologist see the association, and also the clinician to be sympathetic of the pathological information. So I think it's a nice complement to your lecture, but it certainly doesn't encompass.
Any of my pictures, I can usually find them because you have them as well.
That is correct, Bob. I have a large collection of your pictures should you ever need any. Anyway, I think that this issue, the only plea that I would make to the audience for today is that when you see what you think is totally anomalous pulmonary venous return, be it to a coronary sinus, be it to superior caval vein, be it inferior cavally draining, you look for other sites of drainage, including to the azygos vein. And I think my own personal experience with azygos venous drainage has almost always been with right isomerism.
Yeah. What about but you kept on telling me you had cases of direct cardiac connection with usual atrial arrangement. Didn't you have half a dozen of those?
I've had 2 of those, Bob, which is somewhat less than half a dozen.
Indeed.
But, and I have problem verifying the atrial situs because the surgeon was an adult surgeon that just went in, opened the heart, and saw all of the veins draining, were presumably to the right-sided atrium, and simply constructed a pericardial patch to redirect the veins to the left atrium. There was no other intracardiac anomaly whatsoever. I can verify that. But I can't verify the atrial appendage morphology because the patient was much older. And the first...
I mean, it's most unlikely in that setting, as you say,
Yes.
with no other abnormalities to be right isomerism. So I think it almost certainly is a usual.
Yeah, but I've seen that. And I've also seen something that is a little puzzling, is I've seen anomalous veins draining directly, isolated anomalous pulmonary veins draining directly to the right atrium.
Well,
unequivocally.
I mean, a question, Alan McGee has posed a question to me that I've seen in the chats where he says that I should clarify the fact that you can have partially anomalous pulmonary venous connection without a sinus venosus defect, but not the converse. And so what you're saying there is that you have also seen partially anomalous pulmonary venous connection with one of the pulmonary veins going directly into the right atrium in the absence of a sinus venosus defect.
Correct. It's in the app.
Dr. Harmon, there's a lot of people asking the website is MD1World, right?
Yes, www.md1world.com. The book is on the front page. You have to navigate through the chapter. If there's a problem, call me and I'll help you with it.
And just to clarify, Norman, this is an app that can be used on an iPhone, or can it also be used on an Android?
It can be used anywhere, on an Android, on an iPhone, on a tablet of anybody's manufacturer, and on any kind of computer. And once you have downloaded the app, it is yours forever. On whatever device, as long as you remember your username and password, you can access the app off your phone, your tablet, or your computer, and will be updated. So there'll never be a second edition, because when you access the app, you will see the current form of the app.
I use it and it's very good. I've learned a lot. The correlations are good and the pictures are very beautiful.
Thank you very much.
You can see
from my co-authors, Dr. Anderson and Dr. Spicer, and my own personal collection of autopsy specimens.
And you have all the moving bits with all the flow and goodness knows what. So
that's correct.
I'm going to type the website on the chat box, guys. We have some questions on the Q&A box.
Indeed, I've been looking at those, Grace, and I see that Yasser Ahmed Bart is asking, what is the difference between a coronary sinus ASD and unroofing? Well, the difference, of course, is it's not an ASD, it's an interatrial communication, but it is unroofing of the coronary sinus that permits the mouth of the coronary sinus then to function as an interatrial communication. You can have the mouth of the coronary sinus functioning without a persistent left superior caval vein. The ones I've seen and the ones that Diane Spicer has illustrated have typically had the persistent left superior caval vein connecting to the atrial roof, as in the one I showed. But if the walls of the coronary sinus and the left atrium are absent, we don't know yet why they should be absent, but when they are absent, then that permits the mouth of the coronary sinus to function as an intra-atrial communication. So there is no difference. Now, Dr. Arithbana is asking about obstruction. I mean, Norman, you know more about obstruction of pulmonary venous drainage. Can you see the question there?
He's asking, in obstruction in the drainage of the pulmonary veins, how frequent is it to find obstruction in the mouth or in the other cases throughout its course? So he's asking about the location of the obstruction.
I think it's not common to see obstruction to the mouth of the coronary sinus, but it does occur. I've seen cases, and surgically, if this is not recognized, this creates a huge problem. So you've got to be very careful, because if there's obstruction and you don't do the anastomosis appropriately after surgery, you remain with persistent obstruction. And that can be a big problem, of course. Just a word about obstruction to the lower pulmonary veins. I'm sure that Dr. Anderson's diagram of the hemodynamic vice is so beautiful that there's no further explanation necessary for the obstruction that occurs in supracardiac veins that go through a vertical vein to the innominate vein. I thought that was so beautiful. One of the things about venous drainage is that it's quite variable. If you look at the back of your hand or both hands, they don't have the same venous drainage. And if you look at the fellow's hand, who's next to you, or somebody else's hand, you'll see that the venous patterns are variable. And so for vertical veins that go above the heart, the veins have to run between the bronchus and the pulmonary artery in order to create the vice. And most of the time they don't. And what Professor Anderson perhaps didn't get time to mention, which I think is important, that if you look at obstructed pulmonary veins, the commonest variety of clinically of obstruction is to a vertical vein, simply because those are much more common than the other variants. Veins that drain below through the portal vein can be obstructed at several sites. Because they run through the esophageal hiatus, they may be obstructed there. They may be obstructed within the porta hepatis, and of course they may be obstructed at the ductus venosus level. And we have seen a number of patients in whom the ductus venosus is closed, and there's late presentation of infradiaphragmatic types of anomalous pulmonary venous return. Under those patients, the portal system within the liver, the venous system, are usually very, very large from the obstruction. And of course, obstruction within the hepatic sinusoids is the norm, because normally the portal venous circulation pressure is between 2 and 3 millimeters of mercury, and the venous pressure on the systemic side is lower, so that there's a very small gradient of pressure or pressure drop between the centrilobular and the peripheral venous drainage. But when you have pulmonary venous veins draining, you can say at least the pulmonary venous pressure is about 10 millimeters of mercury or greater. And then, of course, between 10 and 3 or between 10 and 2 is a marked pressure drop. And so that by virtue of just the normal hepatic circulation, you have obstruction within the pulmonary veins. So there are really 4 sites of obstruction that occur in the pulmonary veins, and I've seen them all.
And correct me if I'm wrong, Norman, but the presence of these venous lakes in the liver is a very good echocardiographic sign, is it not, of obstructed diaphragmatic connection?
It's like a red flag, Bob. Just like one of your labels, I think.
Absolutely.
But that is very, very, very worrying when you see that. And it usually means that the ductus venosus is closed. And these patients will remarkably and rarely present because they often die. But if you see somebody at 30 days of age with infradiaphragmatic venous drainage, you will see all those circular big structures in the hepatic veins.
Now we have a good question here that you can probably help me with, Norman, because partial anomalous venous connection, what is the clinical presentation? And oftentimes it doesn't produce severe symptoms, does it?
Absolutely. The problem with anomalous pulmonary venous return, partial, is that again, it's a physiological issue because the preferential flow is from a high pressure to a low pressure system. And pulmonary venous pressure is usually a tad higher than the systemic venous pressure. So there's preferential flow into this anomalous vein, and throughout life, it may increase. And so a vein which is small and may appear insignificant in the neonate may have much greater flow in childhood and later on in life. So you have to keep on watching these things. And when you have mixed venous drainage and you, there are two options. The one is to try and re-anastomose the vein to the other veins, and usually that's unsuccessful. And if you leave it, then what you're left with is partial anomalous pulmonary venous return. And that requires ongoing assessment to see whether the venous drainage is very large or not.
And
if
we have
it is enlarging throughout life, that you consider repair of that condition.
we have another question here, Norman, from Mohammed Al-Deftar, who is saying, direct connection of hepatic veins or portal veins to the right atrium when the inferior caval vein is not interrupted. Now, this is something that I do not get the chance to look at. Do you see that with any degree of frequency?
I haven't seen it at all. I mean, I've seen hepatic veins draining directly to
veins connecting directly to an atrial chamber. You would be thinking isomerism, would you not?
I would absolutely be thinking isomerism.
And then I see we have a question from Jagannath, and I fancy this is Jagannath the surgeon who taught me so much about, he has an amazing series, so we should take great note of this. You've seen this, Norman. He's saying in coronary sinus type, there's one more area where we see the obstruction, which is where the common chamber enters the dilated coronary sinus.
Yes, I've seen that too. I've seen that, and it's not common, but I've seen that. Let me just say one thing about the hepatic venous drainage, and that is interesting in isomerism, is that I've seen two varieties. I've seen variety where it drains to the supracardiac, supradiaphragmatic portion of the inferior vena cava, but I've also seen it draining to the atriums. And when it drains to the atriums, it's very interesting because it may drain centrally, but it may also drain to the corners of the atrium, to the left corner of the atrium and the right corner of the atrium. So almost reminiscent of the fact that they are split between the various bodies of the atrium.
We have another question from Dr. Magzandi, who said, again, the difference between abnormal connection and abnormal drainage. So to repeat, this is when the pulmonary veins can connect normally to the left atrium, but because of another communication, that normal drainage can still, normal connection can still drain anomalously. And the classical one for that is the levoatrial cardinal vein. And then the other one, as I showed, is fenestrations of the coronary sinus. So the blood is getting into the left atrium. It can't get out. So there's an overflow. We typically see this in the setting of hypoplastic left heart syndrome with intact atrial septum. And then what the overflow there, either the levoatrial cardinal vein or the fenestrations. And Norman, without the overflow there, that's a very bad prognostic feature, is it not?
Absolutely. Also, in terms of the so-called levoatrial cardinal vein, we recently published a patient that had a left superior vena cava coronary sinus. I sent you the information, Bob. And this patient had an LSVC to the coronary sinus and a levoatrial cardinal vein. Indeed. And you pointed out correctly that the coronary sinus deserves the anterior cardinal vein analogue, and that this is really an anomalous pulmonary vein. And in terms of levi atrial cardinal veins, they don't normally drain only to the vertical vein, but I've seen them drain to the right superior vena cava as well, as you see with some partial anomalous pulmonary venous return.
And then we have an excellent question from Jason Tan, who makes the point that can the pulmonary veins themselves be intrinsically stenosed in the setting, particularly in the setting of Eisenmenger? Jagannath was also making comments on that in his series. There are instances where the anomalous pulmonary veins can additionally be stenotic, and that is a real problem for the surgeon. That's a nightmare. And I think pulmonary venous stenosis in itself is a nightmare. And then you have this business of the so-called sutureless technique, which is far from being sutureless. I think that's a terrible term. But certainly the veins can be. Jagannath has the most amazing series he's put together, he was telling me, because I commented that I gave this talk last week to the Indian Association of Cardiovascular and Thoracic Surgeons. Jagannath has put together a series of 1,000 cases. The material they have now in India is truly spectacular, and I'm learning so much on a regular basis by my presentations to the Indian Association. So Jagannath knows far more about it than I do, but he was commenting how the presence of pulmonary venous stenosis, certainly for the surgeon, is a nightmare. And Norman, you must have come across that with all your experience with the surgeons you've worked with.
I must say that we do see small veins in the fetus, but isolated stenosis of the origins, I think, is a postnatal development usually. And I think that unfortunately the surgeons get to see these patients late. Often they get repaired and then there's a venitis or some kind of reaction that occurs within the endothelium of the pulmonary veins that causes them to be obstructed. And I think that's the reason why there's failure of surgical repair, because it's not just at the orifices of the valves that you get stenosis of their veins, that you get stenosis, but that it occurs throughout the veins, and there's some kind of a reaction that occurs within the veins that causes them to become obstructed. And of course, under that circumstance, sutureless repair doesn't do anything, because the problem is in the pulmonary veins themselves and not in the anastomoses.
Another question here, Norman, that you can answer from Muna Ahmed, who says, does prostaglandin have a role in obstructed infracardiac totally anomalous pulmonary venous connection?
I don't think so.
Right.
Yeah.
I think the answer is that is the last remaining surgical emergency. And your good friend Marshall Jacobs has published a short paper on the fetal recognition of infradiaphragmatic totally anomalous pulmonary venous return with obstruction, where the patient has been moved straight from the delivery room into the operating room without an intermediate cardiac catheterization. And the echocardiogram was done on the table before the surgeon prepped the patient for venous repair. And he's done that a few times as well.
So
this is very a severe situation, and we face that on the CICU. There are some experimental publications saying that prostaglandin has a role in reopening the venous duct. So maybe it can help the obstruction because it can reopen the venous duct. Of course, you need to send these patients to surgery as soon as possible, but sometimes you don't have a fetal diagnosis, and sometimes you're not in a center which can have this surgery. So this is experimental data. And there's some case reports, some publication that patient would improve when we start prostaglandin. But in general, the best way to deal with these patients is to send to the OR.
Let me just say something else. Of course, if it's late and the ductus arteriosus is closed, that could be a good thing. But if you give a prostaglandin and the ductus is open, all you're going to do is increase the pulmonary blood flow. If you increase the pulmonary blood flow, you're going to increase the obstruction, even if you open the ductus venosus. And I do believe that prostaglandins affect venous duct as well as arterial duct. And certainly if you have a patient who has a transposition, for example, if you give prostaglandin before putting in an umbilical venous catheter, your chances are much greater of getting across the venous duct than they were in any other way.
So there's a good question here from Salim Ahmed, who's asking the role of incorporation. And I presume here he's referring to the developmental background to total anomalous pulmonary venous connection, because of course the pulmonary vein is initially a solitary entity which connects the intrapulmonary veins to the left atrium. There's a lot of nonsense being written about the pulmonary veins developing from the systemic venous sinus. That's nonsense. That doesn't happen at all. The pulmonary vein canalizes within the dorsal mesocardium, and it connects the intrapulmonary veins to the left atrium. So we have totally anomalous pulmonary venous connection when that solitary primordial strand that becomes the pulmonary vein fails to canalize. The interesting thing is that on occasion, it can be atretic. So I have seen one heart in which the pulmonary veins form a confluence, and I've found an atretic strand between the four pulmonary veins and the back of the left atrium. So it can fail to canalize and show the connection between the pulmonary venous confluence and the left atrium, but usually that is not the case. Usually systemic collateral channels develop between the intrapulmonary veins to the systemic veins. In fact, they're there all the time, and then they take over the drainage, and that's why you get the totally anomalous pulmonary venous connection.
Okay, we have some more questions if we are able to answer, and then we have to close. You're almost 1 hour and a half.
Malaligned atrial septum. That is a concept that is out there, but it is nonsense. You cannot have malalignment of the atrial septum producing the sinus venosus defect or venous drainage, because when the pulmonary vein connects the intrapulmonary venous channels to the left atrium, it is directly adjacent to the atrioventricular junction. And in fact, the atrial septum, the pulmonary vein is hooked into the left atrium by the vestibular spine, which is part of the atrial septum. So you cannot account for anomalous pulmonary venous drainage on the basis of malalignment of the atrial septum. You will note that I am getting progressively darker as the light goes down in London, because I don't have a light on in my living room. So I think we've done pretty well. Great.
It was amazing. It was an amazing meeting.
Can I just ask one question of Professor Anderson related to systemic venous drainage of the inferior vena cava? Have you seen that in connection with the IVC draining or the ICV draining into the coronary sinus?
No, but there's so many things I haven't seen. I mean, it is feasible. I mean, it's interesting that we're doing work at the moment on normal cardiac development, and there are venous channels all over the place. You made the point about the multiplicity of venous channels on the back of the hand. I mean, during cardiac development, there are collateral venous channels all over the place, but I've never seen that, but I would not rule it out.
Good, thank you. I haven't seen it either, but my good friend Stephen Sanders from Boston describes hepatic inferior caval vein draining to the coronary sinus.
It's feasible. Early in development, the connections from the cardinal veins are bilaterally symmetrical, so it is feasible.
Okay, guys, thank you very much.
you
It
very
was
much,
an
Bob.
amazing meeting.
Thank you,
Okay.
Grace.
See, Epstein's
Thank you.
next week.
Thank you
Yes.
very much, Bob. You need the light.
Indeed, indeed. Sasha, are you still there?
Yes, I'm here.
You're
Okay.
in the dark. You're really in the dark.
It's the light.
I'm
The
in the
light
light.
is
Bob is in the twilight, and
Yes.
Sasha is in the dark.
Bob was amazing, amazing, very beautiful. Thank you very much.
Absolutely.
Very
Thank
much,
you. Thank
guys.
you very much.
See you next week. Bye-bye.
Bye.
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 Bye. Bye.